Con ustedes, apreciados amigos, el doctor Miguel Regueiro, conocido por todos ustedes. Muchas gracias. Thank you very much for estar con nosotros en PANCCO, su conferencia Prevención y Manejo del Crohn Postoperatorio. Gracias, doctor Regueiro.
Buenas tardes. That is my Spanish. So, unfortunately, as you know, Professor Vallejos was not able to make this, so I am filling in and I am honored to be part of PANCCO. So thank you, and welcome to AIBD as well. I think the next few days will be quite good. These are my disclosures, but my main disclosure is despite my Spanish name, Miguel Regueiro, my history, my grandfather grew up in Galicia, in the northern part of Spain, right by Portugal. And then people see my name and think Brazil, but my father grew up in Argentina. And when he was 17, he came to Philadelphia in Pennsylvania. My mother is from Louisville, Kentucky, and I did not grow up speaking Spanish. My son, though, is nearly fluent in Spanish, so if he were speaking, he may be able to give this in Spanish. I'm going to speak on postoperative Crohn's disease and describe the risk factors and management for how we prevent postoperative Crohn's. So to start, when we think about an ileal colonic resection in Crohn's disease, I think it is important to understand the risk factors for recurrence. We'll review some of the new risk factors, also some of the new trials on medications for preventing postoperative Crohn's disease, and then monitoring and a new algorithm that we published recently on how we should consider monitoring postoperative Crohn's. So when you look at this study, it is interesting to see at the top before 2000 and after 2000, the rates of Crohn's disease surgery have decreased, but still probably all of you in your practices see patients who have surgery for their Crohn's disease, about 30% today. So what do we know? We know if you see the red arrow and imagine an ileocecal or ileocolonic resection, for that second, the surgeon in the operating room, the patient has no Crohn's. The anastomosis is performed, and we know moving from left to right on this slide that recurrence of Crohn's disease is silent. Many of our patients will tell us the best that they feel asymptomatic is usually the year to 2 years after surgery. However, when we do a colonoscopy, the rates of recurrence can be quite high in what we see. And then ultimately, about 50% of patients by 10 years have another surgery. So what are some of the risk factors? And this is a new study that was actually just published recently, looking at factors such as gender, race, smoking, time to colonoscopy may be predictive POR, postoperative recurrence of Crohn's. This is a table we put together as part of a review article. Many words, you don't have to read the whole table, but some of the factors in terms of what we understand as old risk factors. Somebody who has their second, third, fourth surgery. You've seen these patients, the natural history is such, they are more likely to have another surgery. Penetrating or fistulizing complications, cigarette smoking. But there have been a number of newer risk factors that I put in green here, and some of these are based on NIDDK studies, some of these are based on environmental genetic associations, gender, the type of surgery, margin involvement, race, and the time to surgery and colonoscopy. What we do know is that cigarette smoking in the newer data and the older data is probably the one modifiable risk factor in terms of the high rate of recurrence, and is the one risk factor from a lifestyle standpoint that we should and could modify. So these were some guidelines that I was involved with several years ago with the AGA, looking at postoperative Crohn's disease. And basically, we broke this into low risk for recurrence and high risk for recurrence. The low risk for recurrence patients, single surgery after many years. I will tell you today, unlike 15 years ago when I gave this talk, not every patient needs a medication after Crohn's disease. And I think we can monitor a group of patients as long as we follow them closely. However, the high risk for recurrence are the patients that we would recommend a medication after surgery. So this is a study that we led out of Cleveland Clinic with several other centers across the country. And what we found were a couple of things. In patients who have fistula, cigarette smokers, high risk for recurrence, what we actually found are those risk factors were real, meaning that those are the patients that we should probably monitor and actually treat with postoperative medications. What we also found in the green arrow looks at prior to TNF and after, meaning that using a biologic after surgery in these high-risk patients is actually something that modifies risk. And this was something we published last year, but there have been many studies that have actually shown the same thing. For all of us in the room and all of us who will watch this video, the main question still becomes, in a patient with surgery, should we wait, not place them on a medication and follow them and monitor, or should we start a medication within 4 weeks of surgery? And that still is the question that we need to answer. You've probably been familiar, this is a study POKER, it's not a new study, but I pull this up because this is an important study which simply looked at half the patients in the study had a colonoscopy at 6 months, and if they had active Crohn's at 6 months after surgery, their medicines were changed. The other half of the patients had a colonoscopy at 18 months. That was the study. In essence, that was the primary endpoint of the study. And what was found were the patients that we monitored, that we looked earlier, had a reduction in post-op recurrence because we saw the disease at a time when medicines could be started and the natural course could be changed. So simply, the POKER study says we should monitor our patients, and I'll show you some of the newer monitoring with fecal calprotectin and ultrasound, but that really derived from the study. So all of us want to know, in a patient with high risk factors, what is the best medicine? What should we use after surgery? Well, this is a table that we put together as part of a review article recently, and you'll notice at the very bottom anti-TNF, but the very bottom, and for those that went to ECHO, saw the Reprevio study, which I'll briefly mention, and this was just recently published. But metronidazole has been evaluated, and a number of other agents. The older study now, and it's interesting to say older study, is the randomized placebo-controlled study that we did years ago, the small study, where red was placebo, yellow infliximab, looking at endoscopic recurrence at 1 year. And this is a study I did in Pittsburgh before coming to Cleveland, and we saw very dramatic differences. This was a very high-risk group of patients, by the way. But this led to the PREVENT study, which we published several years later. In the United States, the Food Drug Administration, or I should say the Janssen at the time, wanted an indication in the label. So clinical symptoms was the primary endpoint. And I just told all of you, many of our patients have no symptoms after surgery. So not surprising, compared to placebo, doing nothing, we did not see a statistical difference. If you look at the left side, blue is placebo, gray is infliximab, and you can see statistically the numbers are similar. However, we do see a trend with infliximab. But the secondary endpoint was endoscopic recurrence, and you've seen these data before. If you look at the left-hand side, I think that tells the story. One thing I will tell you, if you look at the gray bar, 22.4%, people often ask with infliximab, and now it's being true with vedolizumab and other therapies, if you place a patient on a medication after surgery, you have not cured them. It's not 0%. It's in the range of about 20 to 25% recurrence. In my opinion, and I'll show you vedolizumab in a minute, I think this is probably going to be true of any of our current therapies today. Maybe in the future, we'll come up with the magical treatment that will bring that recurrence rate to 0. We also know, and the question comes, what if we continue infliximab or TNF after surgery? And we have, without saying too much, an abstract we just submitted to DDW that looks at a larger number. So imagine your clinic for a minute. You start infliximab 4 months ago on a patient who already has a bit of a stricture, and you say, you know, I think this patient's going to need surgery. Continuing or recycling the TNF after surgery has shown high efficacy. The patient who's had infliximab for 3 years and has progressed to surgery has failed that mechanism. That's a bit different. But recycling the same therapy will work. What about vedolizumab? I imagine if you've been to ECHO or if you actually just saw the recent publication, or if it's not fully published, it will be soon, Reprevio, showing vedolizumab to prevent post-op Crohn's. If you focus just on the left side for a minute, and in this graph, the purple is actually vedolizumab, the gray is placebo. Far left is looking at the I0, 1, or 2A, the low endoscopic recurrence. And then just to the right of that is looking at the more high. The very far right-hand side looks at an I0. And the bottom line is that vedolizumab had a reduction in post-op Crohn's. One thing you'll see in parentheses under the title is 6 months. A difference between the infliximab PREVENT study, which was about 18 months, and this Reprevio this is 6 months. So the question becomes, what will this look like over time? Many of you may say, well, okay, great. What medicine should I use after surgery? If this is the first biologic I would be using, is it better to use vedolizumab or is it better to use infliximab? So we always say this when we lecture. I'm about to do something very bad, and then I'm going to compare across 2 trials, but they're not comparative effective, but I think at least it helps us visualize some of the numbers. So on the left-hand side is PREVENT infliximab. On the right-hand side is Reprevio vedolizumab. Again, different methodology, different time lengths, but what you can see is that number around 20% in terms of clinical recurrence. If you look at endoscopic recurrence, and I just wrote the numbers up top, infliximab was 22.4%. What I didn't write here is that's at 18 months, so a longer time for follow-up. Vedolizumab is 23.3% at 6 months. So are they the same? We cannot say that. Was there a reduction in endoscopic recurrence? The answer is yes. In my opinion, it might be more about when we start the postoperative medicine rather than which advanced therapy. And if I were to predict, and what we're seeing with the interleukins and some of the other therapies, it's going to look very similar. It's when, within 4 weeks. Within 4 weeks. If you're going to use a prevention strategy, it should be within 4 weeks of surgery. Is surgery a cure for Crohn's? I know we have some surgeons in the room, and some of them may think that they can cure Crohn's disease, and I'm looking at a few of the surgeons now, and they know that it's not a cure for Crohn's to do surgery, but it is something. The question is, does the anastomosis matter, and does the type of surgery matter? I'm going to spend just very brief on the surgical aspects, but is surgery a cure for Crohn's? I think we all know the answer is no. Is surgery important for Crohn's? Absolutely yes, and our patients often require this. The question is, does the anastomosis matter? Crohn-OS, a wide resection of the mesentery. The studies were called the Crohn-OS study and then the SPICY study. Well, one thing we know, and it's interesting, is surgery actually a first treatment of Crohn's? So the LYRIC study, which is not a new study, but I put it up here because this is a provocative study. This is an interesting study to make us think about Crohn's and the treatment. So this is looking at a short ileal Crohn's patient who the first treatment was surgery or the first treatment was a TNF. And essentially what was found was the quality of life was no different between the two, but the cost was higher with TNF. The longer-term LYRIC study to 5 years, and I put this in the red letters up top, you can see that those that had surgery, a low percentage required infliximab, and none of the patients required another surgery. And then there was a more recent study that was led out of Mount Sinai, looking at a Danish registry, that similarly found that patients who had first treatment with surgery, had lower rates of postoperative recurrence. About 50% of the patients who had surgery did not require a biologic. In the United States, I'll tell you, this has not been adopted as widely as it has been in Europe. And I'm not saying that we should or should not recommend surgery early for all of our patients, but I do think there are a subset of short ileal Crohn's patients that would benefit from surgery. So generally for the post-op in terms of the type of surgery, I still think we're trying to decide who do we wait and watch, who do we actually act now. I'm not going to go through this in too much detail, and if there are questions at the end, I'm happy to answer, but the Supreme study is looking at a Cono-S anastomosis. Actually, how many people are surgeons? Just to get a sense. So there's definitely a handful. So there's the Cono-S surgery, which some of you may be performing, which actually showed a lower rate of recurrence initially. However, what was just shown at ECHO this year calls into question whether or not Cono-S actually has a lower rate of recurrence. I think we still need some of the data. And then the SPICY study, the real reason I show it is I love the name. The SPICY study is actually looking at resecting the mesentery. So if you look at the extensive mesentery, you can see the cuts on the left-hand side, taking out an extensive part of the mesentery versus just part of the mesentery and the anastomosis. And the bottom line is, without, again, going through too much detail, we don't think that taking out a large part of the mesentery actually prevents post-op Crohn's. Now, I can tell you at Cleveland Clinic, our surgeons do surgery a bit differently. Some do believe the mesentery is important and will take out a larger amount. Some will do a Cono-S surgery. So I just think we need more data. And then finally, monitoring. So Chuck Bernstein and I last year published How Do You Monitor After Crohn's Disease? And this is just kind of a simple guide from the conclusion of our paper. And what we suggested, aside from a colonoscopy, which still I think at 6 months to a year after surgery should be performed, you'll see intestinal ultrasound. Who does intestinal ultrasound in the room, just out of curiosity? So a smaller number than there were surgeons. So still this is not widely adopted, but I do think one of the best roles for intestinal ultrasound is monitoring post-op Crohn's. However, a fecal calprotectin is readily available. In my practice, at 3 months, we'll do a fecal calprotectin. If it's 150 or higher, we will plan on doing an early colonoscopy. We do have 2 of our gastroenterologists do intestinal ultrasound, and now we're starting to do that, especially in those patients as well. But I still think a colonoscopy is a reasonable test in many of these patients. And then finally, I think the future will become more of an individualized approach. The microbiome clearly plays a role. I do take the opportunity to talk to my patients about diet. The diet studies in terms of post-op Crohn's have not been great, but I think that this is an opportunity to talk about processed foods, low carbohydrate foods, and the like. So this is really my final slide, and I've changed this slide over the past 15 years to update this with data as it comes out, so this is a bit of an iterative or fluid slide. In the low risk for recurrence patients, I think those patients who are on their first surgery, don't have penetrating disease, it's very reasonable not to place those patients on medicines. Maybe we do discuss diet and take that opportunity for those patients. 3 months, I do a fecal calprotectin. If you have access to an intestinal ultrasound, I think that 3 to 6 month window is when you would do the ultrasound. And then 6 months to a year, if they're not on any medicine, do a colonoscopy. And if they're an I0, leave them alone. Do not place them on medicines. And then finally, the high risk factor patients, these are the patients who are on their second or more surgery. They have penetrating complications. These are the patients, if I were to have a naive patient, I still think the data with TNF inhibitor, with infliximab and adalimumab, probably has more robust data at this point long-term than vedolizumab, but vedolizumab is not a bad choice, and I would say between doing nothing in high risk or vedolizumab, I would certainly use vedolizumab. And I think we can use monotherapy TNF in these patients because they have some of the highest levels. So with that, thank you to PANCCO, and thank you for having me today. I'm sorry I'm not speaking in Spanish, but hopefully you understood my English. Thank you very much. Did you want me to stay for questions, or should I move? Yes? Oh, okay.
Si tienen preguntas, entonces podemos traducir para que el doctor Regueiro las conteste.
Can be in English or Spanish.
If the microbiome is altered, have you considered using, aside from metronidazole, probiotics in the post-op period?
So there have been, that's a very good question. There have been a number of probiotic studies. Unfortunately, to date, the probiotic studies and the probiotics that have been used have not shown a difference in terms of post-operative recurrence.
Se han utilizado probióticos, pero los estudios con probióticos no han demostrado una diferencia utilizando los probióticos que tenemos disponibles en la recurrencia posoperatoria de la enfermedad de Crohn.
And it may simply be we don't have the correct microbiome altering agent.
Y puede ser simplemente porque no tenemos el probiótico indicado que altere la microbiota del paciente. Sí, doctor Julián. Okay. So he wants to thank you for being here and teaching us about IBD, and wanted to know why the studies like the PREVENT study and the vedolizumab study that you mentioned did not show differences in the clinical symptoms, but they do show differences in the endoscopic symptoms.
A very, very important question. I think one thing I will say now, learning from the PREVENT study and confirming with the Reprevio study, going forward, it is likely, based on the FDA, that we will use endoscopy as the primary endpoint. And then I'll say something else, but if you want to.
Basado en el estudio PREVENT y el de vedolizumab que el doctor mencionó, y siguiendo las guías de la Food and Drug Administration, se va a utilizar la evaluación endoscópica como el punto final para las indicaciones de estos medicamentos.
But the reason, as you know, the clinical recurrence rates were so low, many of the patients who have a resection will not develop symptoms of recurrence, sometimes up to 5 years. So the symptoms are probably not the best indicator of recurrence. Endoscopy or fecal calprotectin would be.
Y los pacientes presentan una recurrencia clínica tan baja porque algunos de ellos no presentan síntomas hasta 5 años después de la cirugía, después de la resección quirúrgica. Entonces, no se considera un indicador confiable de la recurrencia de la enfermedad.
So just to repeat the question, I guess you can say it in Spanish, when would you use azathioprine in post-op Crohn's?
¿Cuándo se utiliza azatioprina para Crohn's postoperatorio?
I think honestly today, never. I should be careful though. If you do not have access at all to a biologic, an anti-TNF or vedolizumab, it's reasonable to use azathioprine. However, all of the studies have not shown azathioprine benefiting endoscopic recurrence, did not show benefit.
La azatioprina no se debe usar, aún así, en los casos donde no hay acceso a los anti-TNFs. La azatioprina se podría usar, pero los estudios que evalúan la recurrencia endoscópica postquirúrgica no han demostrado ningún beneficio utilizando azatioprina. O sea que aunque uno no tenga nada, es como placebo.
Yeah, so currently I am not. You could use it in combination with a TNF inhibitor, but even then you probably don't need the combination because the levels of TNF are so high after a resection. There's no inflammation.
Se puede utilizar en combinación con un anti-TNF, pero no es recomendado porque en general no es necesario utilizar la azatioprina como inmunomodulador en estos pacientes porque los niveles de anti-TNF son tan altos porque no hay inflamación en esos pacientes una vez pasada la resección quirúrgica.
¿Ha utilizado upadacitinib en recurrencia postoperatoria alguna vez?
Have you used upadacitinib for surgical recurrences?
So yeah, the question about upadacitinib, have I used it? I have about 4 or 5 patients. The numbers are very small. My sense is that it will look similar to infliximab and vedolizumab. The patients I've used upadacitinib have been already failures of TNF and failures of vedolizumab.
Él tiene 4 o 5 pacientes con upadacitinib y la percepción que él tiene es que se va a comportar similar a los anti-TNF y el vedolizumab. Los pacientes que él ha empezado en upadacitinib son pacientes que han fracasado en el uso de anti-TNF o vedolizumab, o sea que se han tenido que cambiar.
Thank you.
Thank you.
Yeah, thank you for doing that. I appreciate it.